once again to the Race Academy webinar series, episode 23. It's the year is flying by. We're now halfway, and looking forward to again getting Professor Michael Stubbs on board. But before I hand it over, I want to welcome all our guests. I believe we have guests in from Australia, of course, New Zealand, Singapore, Scotland. Hello to our Scottish folk, India, Malaysia, and hello to the Canadian guests as well. It's so exciting to see us bringing the world together, not only on a manufacturing platform, but on an educational platform. And today's topic is one that has been requested by a couple of our clinicians who want to understand better how to detect oral cancer. So again, we've managed to talk Professor Stubbs into joining us. He's a wealth of knowledge, and no one knows more on the topic. So if I could pass it over to you, Professor Stubbs, welcome.
Thank you very much, Matt. As always, thank you for the compliment. I'm just going to pull this up. Now, let's see. Here we go. So I think most of us in dentistry, when we look in the mouths, we obviously appreciate the fact that there are lesions that we may notice or changes in the tissues. And I suppose one of the questions we always ask ourselves, isn't it, is, well, is this normal? Is it abnormal? What about if I'm missing something? What about if this ulcer, for example, this change in the tissue might be something we might call cancerous rather than necessarily something benign? And I thought in my years of experience, I'd just like to share a little bit about some basic fundamentals when you're examining patients. And I also thought I'd like to share with you some of the technologies that exist when you screen the oral cavity, and in final commentary, just some strategies about how best to manage a patient. What's the protocol perhaps you should follow if you suspect the patient has a lesion of some unknown cause? So let's begin. I mean, here we can see a gentleman on the right side, the left side, my left side, that has a rather large swelling here. And obviously in the mouth, he's got a very large ulcerating growth, the mandible. So this was actually a very advanced squamous cell carcinoma. 90% of patients who get cancers, carcinomas in the mouth, the oral mucosa, is squamous cell carcinoma. You might be interested to know that one of the other most common ones is lymphomas, actually, but carcinoma SCC, for abbreviation purposes, is the most common. So someone like him is probably not necessarily a common finding in your practices. The reason being is most patients you would think in, say, Australia, certainly first world country, might have been picked up before it got to this advanced stage. But sadly, it does happen, and we do see them. And, in the Australian context, certainly you may note here I put that 5-year relative survival rate from 2011 to 2015 for pretty much most oral cancers was 75%, compared to 69% for cancers all combined. So what that really means, in other words, is that we're getting better at our patients being diagnosed earlier, which gives them much greater chance of surviving more than 5 years. And sadly, often a patient is, because they're not diagnosed early, it might be, for example, the patient has, in many cases, the lesions are asymptomatic. They don't even know they're there. I mean, how many times do you ever check under your tongue or the floor of your mouth? And bearing in mind, we're in the dental profession. So they can grow or change without them knowing. And secondly, sometimes our own, as colleagues, we may not necessarily look for it, or we may not notice it. And so in the end, when they do get it diagnosed, and particularly if they're in an advanced stage, their chances of surviving treatment is much less than, say, somebody who's picked up early. And this is some of the more recent data that I could find. I'm not saying it's the only data available, but in Australia, for example, in 2015, there were 3,407 oral cancers diagnosed, but 935 of them were on the lip. And it's interesting too, because lip cancer is incorporated or included when we talk about oral cancer. And without stating the obvious, it should be, because the lips are part of the oral cavity in effect. And in southern Australia, certainly we have the highest incidence in the world of UV exposure. So lip cancer, or lip squamous cell carcinomas, is probably one of the highest incidence in the southern hemisphere, occurs in southern Australia. We know that, for example, melanomas have a higher incidence, particularly in the northern part of Australia. And it's just interesting the differences that exist in the country. And you might also be interested to know that there is a difference in the lifetime risk of developing cancer. Now, sometimes that can be due to lifestyle factors, which I'll touch on briefly. 1 in 90 men and the likelihood of 1 in 200 women developing an oral cancer, particularly SCC, squamous cell carcinoma, in their lifetime. So it's a fair number. And we also realise that for most patients, the risk factors, we call them lifestyle factors, is cigarette or tobacco use, certainly the consumption of alcohol. The combination of tobacco and alcohol is a dynamo. It actually has a multiplicative effect as far as risk is concerned. So, for example, if I was to suggest to you that you're 5 times more likely to get oral cancer if you drink alcohol compared to somebody who doesn't drink alcohol, and I'm talking about what we might deem as moderate to heavy usage, 4, 5, 6 glasses a day, you might have a 7.1 times chance of higher risk of getting oral cancer if you smoke cigarettes compared to those that don't smoke cigarettes. And this is in the male population, but you're 35 times more likely to get an oral carcinoma in the mouth, certainly from smoking and alcohol. And the human papillomavirus, you can see the image on the right, which I did extract from a journal article, but it's a really interesting image of what HPV looks like. Human papillomavirus, there's about 100 that literally can affect human beings. And it's the human papillomavirus strains 16, 18 are the ones that we interest ourselves as risk factors, especially 16, in combination as a precursor for developing SCC, squamous cell carcinomas. So, for instance, you know, there are many times, perhaps 75% of times, you can associate maybe a patient who smokes or drinks alcohol who have an oral cancer. But there are 25% of times really where you might find patients who don't smoke, don't drink, but still get them. And one of the thinking is certainly the human papillomavirus 16, 18 are precursors to that process. There is a silver lining in me saying this, and the silver lining is that in patients who have oral squamous cell carcinomas caused or attributed by human papillomavirus 16, 18, they respond remarkably well to radiotherapy. And they do extraordinarily well compared to those cases that are caused or linked to being caused by tobacco and alcohol. And one of the reasons for that is called field of cancerization. It means when you smoke or you drink alcohol, the entire mucosa, including the pharyngeal mucosa, is exposed to those cancer-causing agents. We call them carcinogens. And that's the rationale reason why, you know, the use of tobacco. There is no such thing as a light cigarette versus a heavy cigarette. The use of tobacco is the risk factor, particularly, that can lead on to oral cancer. And in some cultures, especially Southeast Asia, we're talking about India as well, the use of the areca nut or the so-called pan, which is a mixture of the betel leaf, is one of those things that they love doing. And one of it is because it creates a high. And the interesting thing about it is you might have heard of a condition called submucosal fibrosis, is where patients can't open their mouth. And it occurs because they use or chew on the betel leaf with the areca nut. They chew on it on a daily basis as a high, and it causes lots of scarring to occur inside the tissues. But what is interesting is they also get the abnormal changes on the epithelial surface, which can predispose to the development of squamous cell carcinoma. And you can see here again, you know, in Australia, for example, being a great multicultural country that we are, you know, we'll probably see as time progresses some of these so-called perhaps subcontinent behaviours or cultural behaviours using areca nut and the betel leaf may become more prevalent in Australia, certainly. And it's also interesting that there's no currently any national screening program for mouth cancer available in Australia. Now, you might ask the question, why is that? And I think one of the reasons is we know that if we look at our patients and we identify in the medical history known lifestyle risk factors, you know yourself, if somebody's smoking, what's one of the common things they're going to have too? It's periodontal disease. So you're going to be monitoring them anyway for that. So you should be scrutinising the tissues. The second thing is sometimes squamous cell carcinomas, remember I'm referring to that all the time because 90% of them cancers in the mouth usually are squamous cell carcinomas. They cause from the epithelial cells that line the mouth, a little bit like skin. In fact, we can't often predict a lesion necessarily is going to be there before you develop SCC. So that means in not every case, somebody will have a change that over time progresses. Sometimes they just develop these SCCs. And it's because of that concept I said a moment ago called field of cancerization. It means that when you're ingesting some of those products like the tobacco, carcinogens, the alcohol, etc., even cannabis in some cases, it can actually predispose the lining of the mucosa to become susceptible to cancer changes. So I know that's very fascinating because that's epidemiology, but when we get to the nuts and bolts of what we do professionally, let's talk a little bit about some of the high risk sites. You've got to go through the lips to get into the mouth. So I always encourage you, have a look at the lips. You see here, this is one of my own patients, and he was referred to me because he had these dry crustacean areas you can see on the vermilion border here on the right, and you'll notice there's another one down here. And when I looked at that, one of the things is he's had a lot of sun exposure, like a lot of us in Australia do. So he has a condition we call actinic colitis. It means that they lose the definition of the vermilion border. So see how it's kind of really not very crisply outlined? It's quite blurs into the skin. And that's just because of a lot of UV ultraviolet radiation damage. But what was interesting with the history was he smoked, and that's where he put his cigarette. And so that's where I did the biopsy. And that was squamous cell carcinoma. This one was just that actinic colitis. In other words, it meant that the cells were not abnormal. It was actually just dry and crustated because the lip dried out. So, you know, have a look at the lips before you get into the mouth, of course, and have always check them out for the possibility of dry, flaky lesions, particularly those cases where you see them and the patient might say, oh, yeah, I've always had this problem on sitting on that lip for a long time. And as I said, ask the question, do you smoke? And if they do, where do you put the ciggy? Because often that can be a site of exposure. Here we can see what I just referred to as actinic colitis. It just simply means that through a lifetime of exposure, see how the vermilion border is not that nice pink, it's actually fissured, very crusty and dry, and this is this white, almost diffuse change that you can see just from a long-term exposure of the sun. Again, how do we know that? Because it was biopsied to prove it, and that's important. Lichen planus is certainly something that for many of you watching this will be familiar with. It's an autoimmune disease. It actually is where our T cells target our mucosa in the mouth situation. It also does the skin, can do genitals, do the scalp, can fingernails. And the thing is, you get these changes. You see the white and red lacy pattern. And the important thing about lichen planus is that at 3%, it's actually 2.7%. But if you think about it logically, you can't have 2.7 people out of every 100, but you can have 3. They're likely to become precursors to squamous cell carcinoma. So if you get a patient, let's say, where you look in the mouth and you think, I reckon this is lichen planus, and just imagine you did the biopsy and it came back as lichen planus. One of the things we do in Australia is based on the European protocols. We review our patients once a year and we do good photography. So we've got good evidence, we can see the tissues, and we can make sure if there's any changes in the tissues based on previous photos, maybe the year before, we re-sample the tissue just to make sure that there's not changing into what we would call squamous cell carcinoma. And again, here's a great example, very similar. This is lichen planus here, and you can see also the lichen planus in here, this mixture of white and red tissue changes. And I think most of us who we saw this in the mouth, we would refer them off, I would think, for a biopsy. And that's a very reasonable thing to do because you want to give some explanation also as to what the problem is. And in most cases, as you'll see in the cheek of this gentleman on the left and the gum area on the right, particularly when they're brushing their teeth, it's actually painful. And one of the tricks too is if you get a patient that talks about irritation in the mouth and then you ask them the question, when you brush your teeth, does toothpaste sting? And they say yes, you know you're dealing with an inflammatory condition straight up. And sometimes we see these. I mean, how many of you watching this have seen this before? See that diffuse white change? Now, people like to use this term leukoplakia. It just means a white patch, but we don't know what the cause is. That's what it means. But you can see that. So we look at the floor of the mouth as a high-risk site. We look at the side of the tongue and the ventral surface of tongue. high risk site for developing squamous cell carcinoma. And we also look at the retromolar pharyngeal region, high risk sites. Why are they high risk sites? Well, probably because, number one, they're kind of out of the way sites, and a lot of people don't notice them, whether it be the clinician or the patient themselves. And number two, we suspect that there may be some susceptibility in the mucosa in these regions, floor of mouth, ventral surface lateral border of tongue, retromolar region. There may be some susceptibility in those regions where they do respond more to the cancer-causing agents we call carcinogens. So always cast your eye, particularly over those three important areas. And you can see this is a gentleman. You can see this rather white, thick plaque. Yes, I know some colleagues would say, and we often do say this, for every oral cancer patient you treat, they've usually been to their GP and had 3 or 4 courses of antibiotics, a couple of courses of antifungals, and then finally they get referred on. And so intuitively, someone will look at that and say, oh, that could be oral thrush. But as you know yourself, if they're not a smoker, and they're not immune compromised, sometimes just these white areas, if they don't wipe off, you know, start to think about other scenarios. This is actually the soft palate, hard palate. And this is a patient who's got a full upper denture. Look at these white plaques. See these thickened areas? Again, that's obviously not normal. And in those cases, you would definitely consider a biopsy. You'd be thinking, is this HPV, human papillomavirus related? Is it actually abnormal cells we call dysplasia? And so they're the things we look for when we're looking at a biopsy specimen down the microscope. We're trying to make prediction of what we're looking at and whether in fact these are precursors or they already are abnormal changes which can lead on to SCC. So these are the regions that we would generally say. Now, obviously I would tell you, and I think it's fairly obvious, you check every site. But there's especially the ones, the floor of mouth, ventral lateral surface of tongue, and the retromolar pad region, because they're the out of sight, out of way spaces that you can have these problems. So it's an interesting thing, isn't it? I mean, we've just shown you some photographs and I've also just explained some of the common sites, but what can we do about it? Well, I thought what would be interesting is just talk about some of the technologies that exist. And I'd like to share with you currently the views on some of these technologies. So if you're entertaining the idea of maybe trying them out, and I'm not dissuading you, but I would say to you, just consider the evidence before you go and buy some of these technologies. So let's talk about this one. Firstly, you might consider in basic terms, have a look at your patient that you're dealing with. If they've had a previous cancer, especially, they're much more likely to, particularly if they're related to smoking or alcohol, they're much more likely to have another one, a reoccurrence or a second primary. It means, in other words, a new cancer. So they need scrutinising the tissues on a regular basis, probably every 6 months, depending on the patient. It might be every 3 months initially after treatment of cancer. They usually would go to their surgeon or their oncologist to be followed up as part of their normal follow-up for head and neck cancer patients. But ultimately, as their dentist, you have a job to do as well, and you can scrutinise the tissues yourself. And if there's something you're not sure of, you'd obviously be in contact with the surgeon and ask for advice. So those patients that smoke or drink alcohol, those patients that have had previous head or neck cancers, and they're the ones that certainly are the vulnerable ones for reoccurrences. So you want to keep an eye on those patient groups. And there's a dye called toluidine blue. Now, some of our older colleagues watching this who are my age would know about this one. It's actually, to be candid, not a great reliable test, but it is out there. And what happens is the patient rinses their mouth in the toluidine blue, and then when they spit out, we look for areas where the dye has been taken up in the tissues. So you can see here, for example, the toluidine blue dye, patients rinse their mouth out, and you can start to see all these little blue areas, and here particularly. And what it's doing is it supposedly is absorbed by cells that have high DNA content. That means actively dividing numbers of cells. It's not that reliable, but if you've got nothing else, and this is not in lieu of a biopsy, by the way, folks, this is an opportunity to have a look at the tissues. And often these tools I'm sharing with you, they can be used to pick the best site to biopsy. The biopsy is the gold standard here. I'm not suggesting anything else. But this is something where you can see on the lower left here, see that subtle white lesion? on the left, and then they've done the toluidine blue, and you can see the uptake of the dye. So yes, it's useful to cast your eye and direct your eye to a spot where you should biopsy. But again, it doesn't have a very high specificity for oral changes relevant to cancer, but it is something that's available if that's all you have. And so it's not really part of a routine screening. Some colleagues like using it, but I don't. The VisiLight is a chemoluminescence. It's actually basically a plastic tube with a glass insert that you break, and the patient actually rinses their mouth out with this mouthwash, which is 1% acetic acid, just get rid of all the saliva coating. And then when they place the light into the mouth, what it does is it highlights areas as white where there's a lot more cellular content compared to those where there's not. And so you can see here, for example, this is the labial commissure region where the angle of the mouth. And you'll see with the special light, because you turn the light off so you have a darkened room, you can see this intense white area here. And the basis of that is these cells have a higher nuclear or DNA component compared to normal tissue you can see next to it, which doesn't reflect white. So that would be some site that you'd cast your eye to consider biopsy. And that's all it really is useful for. It's not a replacement of the biopsy. This is what I use in my practice. It's called a velscope. Again, velscope, it doesn't replace the value of a biopsy, but I'll tell you what, sometimes you get patients where they present with, let's imagine their entire hard palate is white, or they might have extensive areas on the floor of the mouth that's white. So the question is, what spot do you choose to biopsy? You can't biopsy all of it. And so we use these type of guides as a directional area to give me a better insight on what spot to choose. So with the velscope, again, you'll see the colleague here is holding the velscope, looking in the mouth. The room's been darkened, and she's actually looking through the lens of the camera here. And with the blue light in the mouth, what she's looking for is the reflection of the green what we say coloration back from the tissue. So we look for structural changes in the tissue itself because of the way it reflects the light back through the camera, so you can actually see the spot you should biopsy. And here we can see an example on the left where we've got a very faint mixed red and white lesion on the ventral surface of tongue. And then you can see they've highlighted that. But before they did the highlighting with the ink, you can see the shadowing here, the dark area. Now what that means is that all that green apple colored light around it has absorbed the light and is reflecting it back as normal. But when you've got structural changes under the surface of the epithelium, you get vascular changes. So in other words, inflammation can look the same. It draws your eye to a spot, and you might say, well, that's a good site to biopsy. And that's what I use this for. And you can see, again, they've put the special ink around the edge of the lesion. And then when they've done the velscope, it actually shows it up. This is another one. Look at the floor of mouth here, down the bottom. You can see the shadowing here. Again, it's just casting your eye to looking at a site that you might consider to biopsy. And in this particular one, which I think really says a lot, you can see here we've got the soft palate, the molar teeth. This is the tongue, the back of the tongue, and you can see the arrows pointing to the polyp. Have a look at the back of the tissue here. You can see the mixture of just the pink appearance of the normal soft palate mucosa. But when they use the velscope, you'll start to notice, in fact, that you've got the green light here, and all of a sudden you've got this very dark, shadowy area. And CIS means carcinoma in situ. So what it meant is that the colleague that did and used the light chose a number of spots to biopsy based on the imaging that they could see. And when they did the imaging, they found that the polyp was just a polyp, which would have been biopsied, but this could have been missed. And when they did look at the tissue, they found that, in fact, adjacent to the polyp, which is where I'm showing you here, was actually abnormal changes we call dysplasia. And where the arrow is pointing in this part here, it actually was much more involved, leading on to almost squamous cell carcinoma. So remember from your undergraduate training, when you get the changes in the epithelium and those cells are called dysplastic, it evolves usually mild to moderate to severe. In other words, it becomes full thickness of the cells, the epithelial top. And once you get to the full thickness, it then invades into the underlying tissue that we call the lamina propria. So that was a really good use of the technology for no other reason. It didn't replace the value of a biopsy, but what it did do was it helped that they minimize the risk of missing something. And you can see here in this particular publication, now there are others, perhaps more updated ones, but they showed 100% specificity and 98% sensitivity. So when you're looking at the probability of missing something versus the probability of picking something up, it's actually not a bad suggestion. And so again, Velscopes are quite good, and that's what I use. And just to explain how they work, remember the colleagues looking through the top part of this, they're aiming the blue light onto the tissues. You can see that the normal architecture of the tissue reflects back with this green coloration. But where there is actually abnormal finding, the cells themselves architecturally different, there's some inflammation underneath the epithelium, it absorbs the light, and so it draws your eye to the darker change, and that's the site that you'd like to choose to biopsy. So these are useful tools in conjunction with a biopsy approach. And finally, this just shows, again, a nice photograph of the hard palate. And again, we can see here with the Velscope, you can see a change showing up rather nicely, and you start to look at the photograph, and that's what would have been biopsy, which was squamous cell carcinoma. So again, it's very easy to miss these things. So you use the tools you've got to your advantage. And when we talk about prognosis, I don't mean to ad nauseum go on about it, but we recognise that as a general rule of thumb, if you have a squamous cell carcinoma on the lip, your chances of surviving 5 years is about 90%. That's excellent. So they tend to metastasize quite late. Metastasize meaning they spread, usually either through the lymphatics or through direct infiltration through the blood. And floor of mouth is about 45% success of being alive 5 years after diagnosis and treatment. And the pharynx, particularly posterior third of tongue, and pharyngeal about 25%. Now, again, those numbers may not, strictly speaking, in 2022 reflect the numbers that I'm sharing with you, which were published in about in 2002. But my point to you is it just demonstrates picking these things up early saves lives. And the TNM, the tumour nodal metastasized staging, again, I'm not going to go into that in great detail, but just simply to tell you that in oral squamous cell carcinomas, they're graded. So if someone says to you as a patient, oh, I had a T3 squamous cell carcinoma, you might look at them and think, what's a T3? What they're really saying is that it was greater than 4 centimetres, particularly if you got a letter from the doctor or the oncologist. They might say something like they had N2A, which meant that they had one node on the same side as the tumour, or they might have had them on both sides. And so the reason they do this qualification here is because internationally, when they talk about a group of patients with squamous cell carcinoma, and we'll talk about head and neck because that's our area of expertise here, that, they grade it according to the severity, and that lends itself to what's the most appropriate treatment. Do they need surgery and radiotherapy, or do they need surgery, radiotherapy, and chemotherapy? And it also means, from the patient's point of view, they can make predictions about survival rates based on the experience from international other facilities where they compare data. So I think, as a final note, for what it's worth, and this is oral medicine in about 15, 20 minutes, but it's actually my advice to you, colleagues, is when you see something, take a photograph. I don't mind saying to you, most of my colleagues that refer to me, we always say to them, send us a photograph of the lesion, and then we can look at the photograph as a guide and we can triage, which means we can try to prioritise and get them in quicker. Secondly, you've got an objective record of to what the lesion looked like. So when you refer it on, just imagine the colleague doesn't see the patient for 3 or 4 weeks. They've got a photograph to compare if it's got bigger or smaller, or otherwise they're just reading your notes. And also eliminate the obvious trauma. I mean, you get an ulcer, for example, what's the most common reason? Well, usually it's mechanical trauma. But if the lesion's been there, let's say you remove a sharp cusp, or a denture needs to be adjusted, and you're talking 7 to 10 days later, get them back. And if they've still got the lesion, it should be biopsied. It should be assessed. And I think, as a general rule of thumb, that's actually the best way to minimise not just your own opportunity to help your patient, but it also means you're doing the right thing by that patient as well. And I think, as a final note, because cancers, even though we've got great treatments these days, whether it be chemotherapy, we've got PET scans now, which can pick up minute activity of cancers, changes in the body, lymphatics in the organs, etc., where it may be occurring. Because we've got that technology, the earlier you can pick the patient, the earlier the condition is detected and diagnosed, the better the chances of survival for that patient. And so the prognosis is always worse if the cancer is started to metastasize. It doesn't mean a death sentence, but clearly your chances of surviving 5 years is greater if the tumor has been removed completely and that there is no metastases. And this is a really, I put this in just to show you, because this is a case where I had a patient who actually had a renal carcinoma. And you might be interested to know that even though the mouth is quite distinctly regionally from the kidney, you can get types of common secondaries in the mouth and lung and breast, but also prostate. I've seen cases where the prostate cancer being a secondary is on the hard palate. I've seen cases where breast cancer secondary has been involving the chin. And also in this case here, this is a renal carcinoma. And without stating the obvious, the reason it was known that is because it was biopsied. And you can see here that the gingiva and the tongue are the most common soft tissue sites, and I'd go the hard palate as well for secondaries, but it can occur. So you got a patient, let's imagine, who had been successfully treated for breast cancer. One of the things you do for your job is you actually scrutinize the tissues. I'm not suggesting that the patient's always going to get a secondary in the mouth, but gee, how great would it be if you actually detected that early and had that patient treated appropriately in the quite a quick stage to actually minimize the likelihood of not doing well long term. And this is one of my patients actually who came and saw me. Just for the benefit of those watching, these are actually little blood vessel clips where the patient had a lesion removed some years ago. But you can see here on the left-hand side of the OPG, this rather interesting mixed lesion. And that was actually a secondary renal carcinoma. And when I met the patient, the referral was based on the fact that they had an ulcer and a raised red area at the back of this tooth. And in fact, by doing a simple OPG, which I think are fantastic radiographs for screening, it actually demonstrated that. We did a CAT scan, by the way, after this, which confirmed the diagnosis. We didn't need to do a biopsy. And of course, we had the benefit of the history. So we knew that the patient had other metastatic renal carcinoma involving the base of skull and the spine, sadly. So, you know, as dentists, we get to see these things sometimes. And again, it comes back to recognising early in the stage and appropriately referring as needed. So I think as a take-home message, if I may, and as a summary, if, you know, when you're looking at your patients, always check out the lips, because recognising, depending on what part of the world you're in, certainly in Australia, we have lip squamous cell carcinomas. Always check floor of mouth, lateral ventral surface of tongue, and retromolar areas. Remembering, of course, other sites in the mouth can have cancerous changes too. They could be saliva tumours, malignant or benign. They can be lymphomas. But squamous cell carcinoma, remember, is about 90% of cases. And secondly, biopsy is the gold standard. And the aim of the game is to get some tissue so we can look down the microscope, confirm a diagnosis, and then the patient is appropriately referred off to a head and neck unit in our world, and to be appropriately treated. And then having the benefit of a follow-up. You know yourself, if you're treating patients who've had oral cancer or head and neck cancer and they've had radiation treatment, one of the common ones, of course, is the concern about taking teeth out post-treatment. And as a general guide for you, when a patient is diagnosed, you usually get about 2 weeks before they start the radiotherapy treatment. So any teeth that are questionable, they might have poor root canals done, they may have already, for example, periapical pathology like a cyst, or they may actually be a poor prognosis. Ideally would be to remove them before treatment. In the case where you can't, you get the first 2 weeks into radiotherapy treatment, where obviously the mandible or the maxilla is involved to get more healing before the healing stops. Because remember, what happens with radiation therapy? blood supply to the bone is eliminated. So therefore you can't get the healing. And then you run the risk of getting osteomyelitis, or what we call osteoradionecrosis. That means the dead bone can't recover because the blood supply has been eliminated through the radiation treatment. And then post 6 months after a radiation therapy treatment, hyperbaric treatment is usually the recommended treatment therapy before a tooth is extracted. So in other words, in your cases where you get a patient who's had treatment and you get asked to follow up, one of the things you might be doing, of course, is looking at the tissues, but you'd also be planning ahead for the side effects of the therapies that they may have had. And we know that radiation treatment is xerostomia, is one, which is our next talk. And secondly, it also means that if you are going to do anything invasive, you always want to know what fields, where are the areas of the jaw that have been irradiated, so you can minimise the likelihood of inducing osteoradionecrosis, which is actually quite difficult to treat. And on that note, I'd like to thank you for listening.
Yeah, thank you, Professor Stubbs. As usual, a wealth of knowledge, and yeah, a part of the industry, or parts of a lot of us don't know a lot about, and especially as a dental technician, know nothing about. But as our clinicians, and showing the importance of early diagnosis, and some of those 5-year survival rates were quite scary yet successful. So I really appreciate you summing that up. I just want to jump straight into questions, if I may, Professor. Where do you get a Villiscope, a VX device?
Look, you can have a look. Some of the dental companies in Australia, they sell them. I think Henry Schein House is definitely one, and there'd be others as well. But you definitely go to a dental supply company, the big ones. They would have them. I bought mine from Henry Schein House.
Oh, that's great. And the next question, I think you've answered with the screen here. What address can we send our photographs of possible cancer cases? Is that the one on the screen?
Dr. Michael Stubbs at hotmail.com. I know it's an old-fashioned email, but it's one I've been using for a long time, and I do check it every day. But you're welcome to. I mean, look, I'm not saying I'm not busy, and I'm certainly not inferring that I'm the only person in Australia that can look at photographs, but I'm very happy for our participants on these race academies, because I think, Matt, what you're doing is fantastic, because, you know, the whole idea of the education is it's about looking at helping our colleagues know more about lots of things in dentistry. And obviously the Race Dental Labs is one of the major labs in Australia, if not the number one. But the thing is, I think it's great because, you know, like what other laboratory would allow someone like me to talk about oral cancer? And I think it's brilliant. So you can pat yourself on the back too, Matt.
Oh, thanks, mate. I appreciate that. We do care, as I'm sure you do too, opening your knowledge to everyone to send their photos through in the hope of helping our patients. And I think that's very important. So Dr. Michael Stubbs at hotmail.com is the answer to that question. I always think of Dr. Michael Stubbs and a Hotmail in the same sentence too, mate. So that's but look, I'm just going to jump straight on. As a general dentist, do you recommend discussing the 5-year survival rates, or do you think that is best done by the specialist? Best done by the specialist. Okay, so just
and to be upfront with you, as I don't treat the patient like once they're diagnosed, I certainly don't discuss it with them either. So in other words, it would be the oncologist or the surgeons involved in their care would be the ones that would talk about it in that context. Certainly not, I wouldn't recommend it for no other reason than the appropriateness of it. And also you want to make sure that what you're telling the patient is right. And in my case, I don't mind saying to you, I do use the figures when I get a patient that's resistant to actually going and getting more treatment done. But basically, I keep that to myself because I think having that knowledge is powerful for me. But certainly, because I mean, if you put yourself in the patient's shoes, and you can imagine you had a squamous cell carcinoma of the side of the tongue, and then you or another colleague said, oh, you've got about a 40% chance of surviving 5 years. It's probably not the best person to be saying it. And so I don't even myself necessarily quote that.
Okay. Oh, that's a good question then. Look, Michael, that's the end of our questions, but I have never, in the 23 episodes of the Race Academy webinar series, I've never managed to be so excited to get to a mirror, to go and assess the floor of my mouth, the tongue, and the retromolar areas. I've quite freaked out, but I'm looking forward to going in there. And look, we do appreciate. I know it's not a scare tactic, but it's a life-saving concept. So look, I think it's super important what you're doing, and I hope all of our clinicians on board today, we have a lot of them, and others who are sharing today. So thank you, Michael. Is there anything you'd like to leave us with as a last minute?
No, just keep up the good work, guys, because men and women watching this, because honestly, at the end of the day, some of our general medical colleagues can be quite dismissive of us as dentists, and they'll say things like, oh, yeah, they just do the teeth. But let me tell you something. We are experts in the oral cavity, and I don't mind saying to you up front, you know much more than a GP medico about the mouth. No question about it. So keep up the good work.
Well, thank you very much, Michael. And look, and thanks to all our people from around the world. And feel free to join us again. Michael will be back. Well, Professor Stubbs will be back after his well-earned holiday. So you enjoy your break, mate, and we look forward to seeing you next year. Everyone stay safe, and thanks for your time.
Thank you very much.